All right, let's jump right into this explainer on the brand new 2027 CPT Coding Guidelines for Intrapartum Care. If you're involved in maternity billing or documentation, you already know that massive changes, and honestly, massive complexities, are on the horizon. The AMA is totally overhauling how we report labor management, and getting it wrong could really cost your practice. So grab a notepad and let's master these new codes together.
Here's our roadmap for today. First, the new 2027 labor codes. Second, straightforward versus complex care. Third, initial versus subsequent day coding. And finally, rules for those tricky special edge cases.
Starting us off, Section 1, the new 2027 labor codes.
So, to get this right, we've got to understand exactly what the AMA actually considers the intrapartum period. According to the new guidelines, this clock officially starts with regular uterine contractions. That's your starting line. And the finish line? The exact moment both the baby and the placenta are delivered. Anything outside those two bookends? Well, it just doesn't fall under these specific labor management codes. Labor itself is divided into 3 distinct stages, and this provides the clinical framework for the whole management process. The progression goes from the initial dilation and effacement of the cervix to the delivery of the baby, and then finally wraps up with the delivery of the placenta. So when we talk about labor management for these 2027 codes, we're talking about the medical supervision and care provided across all 3 of these sequential stages.
Now, what's really fascinating here is just how all-encompassing these codes actually are. The AMA literally wraps maternal, fetal, and complication management into one giant package. I mean, it covers the pregnant patient and the fetus, sure, but it also absorbs the management of all comorbid conditions. Got a patient with diabetes or hypertension, that management is bundled right in. Plus, any pregnancy complications that pop up during this time. Think preeclampsia, abnormal fetal heart rates, or prolonged labor. Yep, they're all included in this single holistic code.
Moving right along to Section 2, straightforward versus complex care. Okay, so once you know you're in that labor management window, you have to assign a level to the care. And honestly, this is a massive paradigm shift. The AMA published specific guidelines separating these into straightforward or complex categories. But here's the kicker. This categorization is based purely on medical decision-making and the associated services needed. It is not just about time. A grueling 24-hour labor that progresses smoothly without intervention, that's straightforward. Time alone does not bump you to complex. And this perfectly illustrates the strict clinical criteria defined by ACOG to formally diagnose prolonged labor. Like we just said, time is rarely a factor for complexity on its own. You have to hit exact milestones of 0 cervical progression in the active phase. That means either 4 hours of adequate contractions or 6 hours of inadequate contractions, specifically with Pitocin augmentation. You can't just guess or eyeball it here. You absolutely must meet these exact definitions to justify complex care.
Let's look at how this actually plays out in real life. Imagine a patient arrives completely stable, but then spikes a fever and shows fetal decelerations 6 hours later. Well, that entire day just escalated to complex labor management. At hour 0, she comes in with spontaneous rupture of membranes, good contractions, stable vitals, no comorbid conditions. Right then, you're looking at straightforward labor management. But, medicine is unpredictable. 6 hours later, late decelerations in the fetal heart rate start, and she spikes a fever. Because of those complications, when you reach the end of the day, you definitely do not bill for straightforward care.
Think of it kind of like locking in your high score for the day. The highest level of labor management performed is reported exactly 1 time per calendar date. So in the scenario we just talked about, you only report the complex code for that date of service. You don't bill straightforward for the morning and then complex for the afternoon. You evaluate the entire calendar date and lock in that single highest level of complexity reached, just one.
All right, on to Section 3, initial versus subsequent day coding. To report those initial day labor management codes, you absolutely must meet at least one of 4 highly specific criteria. It literally has to be the very first date of service for labor management, or no prior labor services have been reported during the admission, or it applies if the patient was transferred from a completely different facility. It also works if a provider from a totally different specialty assumes care for medical necessity, like, say, an escalation of care. Oh, and a quick heads up, this does not apply if a doctor is just cross-covering for their partner on the weekend. Once that initial day is officially logged, everything else basically falls into the subsequent category. The 2 key phrases you need to burn into your memory are daily face-to-face encounters and intended outcome is delivery. If you're checking in the next day and the goal is still delivery, you are operating firmly in the subsequent labor management realm. Okay, let's look closer at these subsequent rules, because honestly, This is a massive compliance trap, so pay close attention. You report this code only once per calendar date per patient. It absolutely does not matter if there are 5 different visits by different covering doctors in the group. If an on-call provider is covering the delivery unit, the daily charge is billed once, period. And what about those continuous visits that span across midnight? The rule is crystal clear. Continuous visits spanning across 2 calendar days are reported as a single visit on just one of those 2 dates of service. So no double dipping just because the clock struck midnight.
So, what about inductions, consults, and multiple fetuses? This brings us to a rapid-fire round of exceptions, because, as we all know, real-world labor units are packed with edge cases. We've covered this standard progression, but what happens when that standard progression totally breaks down? Which leads us nicely into Section 4, Rules for Special Edge Cases.
The AMA has some very explicit rules for handling these consults and exceptions. For instance, you absolutely cannot code initial and subsequent day services on the same date. You gotta pick one. If a provider consults but doesn't actually assume care, they need to stick to standard E&M codes. And this is a big one. If a patient presents for a planned C-section with 0 symptoms of labor, do not use these codes at all. Remember, these are for active labor, not pre-op check-ins.
Now, what if you're inducing labor? Well, you use these specific labor management codes rather than standard observation or inpatient service codes. The AMA is making absolutely sure there's no overlap here. When a patient comes in for an induction, their care is officially categorized under labor management. You are strictly forbidden from tossing on hospital, inpatient, or outpatient observation codes just to pad the bill. The labor management code is comprehensive. It's designed to encompass the whole shebang. And look, the golden rule of 1 strikes again here. Labor management of multiple gestations, like twins or triplets, is still only reported once per calendar day, regardless of the number of fetuses. It doesn't matter if she's having twins, triplets, or quads. The code represents the management of the labor process itself. The AMA guidelines explicitly state that labor management is reported exactly once per calendar date, totally without regard for how many babies are present. Sure, the complexity might shoot up, pushing you into a complex code rather than straightforward, but the actual quantity of codes billed, that remains exactly 1.
So here is the big question. The 2027 AMA rules are finalized, but is your practice's medical decision-making documentation precise enough to actually survive an audit? These new guidelines eliminate a ton of ambiguity, for sure, but they require flawless documentation. As we've seen today, time alone won't save you, and sloppy handover notes definitely won't either. You have to clearly justify your medical decision-making to differentiate straightforward from complex care. You have to rigidly track those calendar dates to avoid overlapping initial and subsequent codes. The rules are clear, the framework is set, but the burden of proof is sitting squarely on your documentation. Will your charts stand up to the scrutiny when these codes go live? That is the absolutely crucial question you need to take back to your teams today.